Pleomorphic adenoma. It is a salivary gland tumor, and the name says pleo means many, morphic means morphologies. Synonym for pleomorphic adenomas, benign mixed tumor. Contents of pleomorphic adenomas. Definition. Pathogenesis. Clinical features. Histopathologic features. Radiographic features. Differential diagnosis. Treatment and prognosis. Definition of pleomorphic adenomas. Benign neoplasm composed of cells demonstrating epithelial and neuroepithelial differentiation, considered a pure epithelial neoplasm with divergent differentiation that may also include mesenchymal appearing elements, myxoid, hyaline, chondroid, and osseous areas. Pathogenesis include neuroepithelial cells. Neuroepithelial cells are responsible for morphologic diversity of tumor, including production of fibrous, mucinous, chondroid, and osseous structures. Differentiation of ductal reserve cells. Intercalated duct reserve cells can differentiate into ductal and neuroepithelial cells, and the later can then undergo mesenchymal metaplasia since they inherently have smooth muscle-like properties. Neoplastic altered epithelial cells. A neoplastically altered epithelial cell with potential for multidirectional differentiation may be responsible for pleomorphic adenoma. Pleomorphic adenomas have shown consistent cytogenetic abnormalities, chiefly involving the chromosome region 12q13-15. The putative pleomorphic adenoma gene, PLAG1, has been mapped to chromosome AQ12. Many other genes have also been implicated. However, cytogenetic or molecular studies do not as yet have an established role in the diagnosis of pleomorphic adenoma. Clinical features. Occurrence represents most common neoplasm of salivary glands, accounting for 40% to 70% of all neoplasms of the parotid, submandibular glands, and minor salivary glands. Pleomorphic adenoma of the sublingual glands is rare. 80% occur in parotid gland, 10% occur in submandibular gland, 10% occur in minor salivary gland. Sex. Slightly more common in women than men. Age. Occur over a wide age range but are most commonly seen in the 3rd through 6th decades of life. Most common salivary gland neoplasm in children and adolescents. Site. Most common site of occurrence is tail of the parotid gland, but it may also occur in the deep lobe of the parotid, in the submandibular, and in all minor salivary glands. Pleomorphic adenoma of parotid gland occurs primarily, but not exclusively, in the superficial lobe, that is, superficial plane to facial nerve. Pleomorphic adenomas of deep lobe of parotid gland may present as a peripharyngeal space mass. Involvement of minor salivary glands occurs most frequently on the palate, hard and soft, but other common sites include the upper lip and buccal mucosa. Symptoms vary according to site. Most are slow-growing, painless mass is present for periods up to several years. Difficulties in chewing, dysphagia, dyspnea, hoarseness, and epistaxis. Other symptoms, in particular those occurring in the minor salivary glands, may include may ulcerate overlying mucosa. In parotid gland, the tumor typically occurs outside of the facial nerve, and facial nerve involvement typified by facial nerve paralysis is rare and, if present, should be suspicious for malignancy. Most pleomorphic adenomas of the parotid gland occur in the superficial lobe and present as a swelling overlying the mandibular ramus in front of the ear. Facial nerve palsy and pain are rare. Initially, the tumor is movable but becomes less mobile as it grows larger. If neglected, then the lesion can grow to grotesque proportions. Sometimes these lesions grow in a medial direction between the ascending ramus and stylomandibular ligament, resulting in a dumbbell-shaped tumor that appears as a mass of the lateral pharyngeal wall or soft palate. Histopathologic features. The pleomorphic adenoma is typically a well-circumscribed, encapsulated tumor. However, the capsule may be incomplete or show infiltration by tumor cells. This lack of complete encapsulation is more common for minor gland tumors, especially along the superficial aspect of palatal tumors beneath the epithelial surface. The tumor is composed of a mixture of glandular epithelium and neuroepithelial cells within a mesenchyme-like background. The ratio of the epithelial elements and the mesenchyme-like component is highly variable among different tumors. Some tumors may consist almost entirely of background stroma. Others are highly cellular with little background alteration. Cellular epithelial predominant pleomorphic adenoma. At higher magnification, cytomorphologically bland-appearing epithelial cells predominate lining ductules as well as in the cellular areas. Chondromyxoid predominant pleomorphic adenoma. At higher magnification, identifiable tubules lined by dual cell type are present extending, melting into the dominant chondromyxoid stroma. The epithelium often forms ducts and cystic structures or may occur as islands or sheets of cells. Keratinizing squamous cells and mucus-producing cells also can be seen. Some myoepithelial cells are rounded and demonstrate an eccentric nucleus and eosinophilic hyalinized cytoplasm, thus resembling plasma cells. These characteristic plasmacytoid myoepithelial cells are more prominent in tumors arising in the minor glands. Vacuolar degeneration of cells in these areas can produce a chondroid appearance. In many tumors, the stroma exhibits areas of an eosinophilic, hyalinized change. At times, fat or osteoid also is seen. Fine needle aspiration biopsy. Background is filled with mucoid to fibromyxoid ground substance appearing bluish-purple with fibrillar appearance and associated spindle, myoepithelial, cells. Cohesive groups of epithelial cells with bland cytology including round to oval nuclei with fine nuclear chromatin and associated magenta-appearing mucoid ground substance. Clusters of plasmacytoid, myoepithelial, cells with associated chondroid-appearing matrix. Radiographic features. Ultrasound. They are typically hypoechoic and may show posterior acoustic enhancement. Ultrasound is also useful in guiding a biopsy, both FNAC and core biopsies, but needs to be carried out with care to avoid facial nerve damage. CT. When small, they have homogeneous attenuation and prominent enhancement. When larger, they can be heterogeneous with less prominent enhancement, foci of necrosis, and possible delayed enhancement. Small regions of calcification are common. MRI. The signal characteristics are homogeneous when the tumor is small. Larger tumors may be heterogeneous. T1, usually of low intensity. T2 characteristically of very high intensity, especially myxoid type, often have a rim of decreased signal intensity on T2 weighted images representing the surrounding fibrous capsule. T1C+, GD, usually demonstrates homogeneous enhancement. Contrast-enhanced axial magnetic resonance image, MRI, of a tumor of the deep lobe of the parotid gland. Serial coronal T2 weighted MRI images on a patient shows a lobulated solitary mass in the left parotid gland. Differential diagnosis include adenolymphoma, oncocytoma, adenocarcinoma, fibroma, lipoma, chondroma, myxoma. Treatment and prognosis. Complete surgical excision is preferred treatment. Parotid gland tumors usually require lobectomy with preservation of the facial nerve. Submandibular gland tumors usually necessitate complete removal. Minor salivary glands neoplasms require complete but conservative excision. Incomplete excision irrespective of site results in recurrent tumor, increased risk of recurrence associated with inadequate surgery, enucleation, rupture or spillage during surgery, chondromyxoid predominant PAs. Diffluent nature results in spillage. Variable capsular thickness coupled with tendency of tumor to invade capsule and or bulge through capsule. Young age. Overall prognosis for PA is excellent with 5-year recurrence-free rate of 97%. 10-year recurrence-free rate of 94%. Complications include malignant transformation, carcinoma x pleomorphic adenoma, and the rare occurrence of so-called benign metastasizing pleomorphic adenoma. Surgical complications may include nerve damage and Frey syndrome, gustatory sweating. Features that may indicate a greater likelihood of malignant transformation include occurrence in submandibular gland, older patient age, long-standing tumor, larger tumor size,